up your mind and see like me. Open up your plans and damn, you're free. I look into your heart and you'll find love, 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 and love. Listen to the music of the moment, people dance and sing. We're just one big family, and it's our God-forsaken right to be loved, love, 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 loved. So I won't hesitate no more, no more. It cannot wait. I'm sure there's no need to complicate. Our time is short. This is our fate. I'm yours. Do you, but do you, but do you want to come on? I scooch on over closer, dear, and I will nibble your ear.
Hello. If you are out in the hall, please make your way in. We're going to get started in a couple of minutes.
I've been spending way too long checking my tongue in the mirror and bending over backwards just to try to see it clearer. But my breath fogged up the glass, and so I drew a new face and I laughed. I guess what I've been saying is there ain't no better reason to rid yourself of vanities and just go with the seasons. It's what we aim to do. Our name is our virtue, but I won't hesitate no more, no more. It cannot wait. I'm yours.
Come on in, folks. We're going to get started. Hope you had a good lunch.
This is a dark parade, another rough patch to rain on, to rain on. I know your friends may say this is a cause for celebration. Hip hip hooray, love. Photographs and sepia tones, so still the fire's barely fighting the cold. Alone. There are times when I can feel your ghost, just when I'm almost letting you go. The cards were stacked against us both. I will always love you for what it's worth. We'll never fade like graffiti on the overpass. I know time may change the way you think of us, but I remember the way we were. You were the first to start. Love that will never leave. Baby, you'll never be lost on me.
All right, everyone. Come on in. We're going to start closing the doors, and I'm going to introduce the next session. Just wait 1 second for the doors to close. I know it can be kind of loud. Okay, I'm going to go ahead and get started. So today, welcome to the overview of clinical trials session. I know this is a much anticipated, voted on session. We are honored to have Dr. Liz Berry-Kravis here, a renowned researcher and pediatric neurologist and professor of pediatrics, neurological sciences, and anatomy cell biology at the Rush University Medical Center. Some of you may already know her from clinical trials or the natural history study. She has dedicated her career to studying rare genetic disorders and is actively engaged in research to help develop outcome measures, biomarkers, and treatments for Phelan-McDermid syndrome, and is a leader in the field of several other disorders such as Fragile X. She is also an engaged member of our natural history study, as I just said, and PMSF's Medical Advisory Committee. Dr. Berry-Kravis will provide an overview of the increasing number and types of clinical trials and discuss current strategies and the phases in design. So please join me in welcoming Dr. Berry-Kravis.
With my glasses or without? Better without. Okay. Hello, everybody, and thank you, Kate, for inviting me to come and talk. And this is really meant to be kind of a clinical trials 101 about what we need to do to get clinical trials off the ground, to do drug development, and what families need to do and how they need to help us in clinical trials. And then at the end, I'm going to talk about where we are in the, a little bit about where we are in the process of some of our early trials, and then later on, Jaguar and Neuron will give more specifics about those trials. So this is a very general session. So this is just really the full process of drug development, and just shows all the steps you have to go through from trying to find a drug and then develop assays that show you're hitting the target, to finding lead compounds and then moving forward with those and studying those in animal models and cells. That's what we call preclinical efficacy, and then look at toxicity in different preclinical models. And then you finally, at the end, get to trials. And on average, it takes 13 years with 5 years in trials and about 9 starting drugs to get to one. And as you can see, it takes a lot of money to do this. So this is something that's done in industry and not typically with the NIH or other sources of funding, because there isn't enough money to do it there. What do we need to do? Once we get to clinical trials, what do we need to do? Well, normally, so this is the typical process for like drugs that are being developed for hypertension, for high blood pressure, for diabetes, or standard drugs where we're treating a symptom. We have a phase 1 trial where we have often normal volunteers. Sometimes when the delivery is a higher risk kind of thing, like an IV or intrathecal treatment, you may treat patients with the disease rather than subjecting normal volunteers to the drug. But usually this is to just really rule out that there's no major unexpected event that we couldn't see in the animal model that is going to be a problem for humans. And so these patients are treated one at a time, and they're watched very closely. Then once we see, okay, nobody had any major problems, now we can move to phase 2, which is a safety study. And so that is that's usually a small number of patients, somewhere between maybe 20 patients and 100 patients, where we're looking at is the drug safe, and usually the primary outcome is for us to measure whether anybody had special problems with the drug or whether there were recurrent problems. And then we're also often looking at a lot of different measures of whether the drug works or not. So that's efficacy. And so often we're looking at, was anything better in the patients who were on the drug? These are usually blinded studies when the drugs are not for rare diseases. For some for some of the rare diseases that are not ultra rare, they may be blinded, but they may not be blinded because really you're just looking for safety as the primary problem. For phase 3, we're looking at efficacy, and in ultra rare disease, there may be an alternative path for this. And so usually after you do a phase 3 placebo-controlled study, then you want to collect long-term safety data. So a lot of times patients will be able to go on the drug after they're done with the placebo-controlled period and stay on it until either the program is dropped or until there's FDA approval. And then after FDA approval, sometimes the FDA requires, or sometimes a company will do on their own, a phase 4 study, which is called a post-marketing study, where we study the drug for a longer period of time because we need to understand what it will do for way more years than we would do in a trial for drug approval. So sometimes there's an alternative path for rare diseases or for serious conditions, and that sometimes involves combining phase 1 and phase 2. Let me see what this is doing. And sometimes the phase 1/2 patients may be allowed to go in a long-term extension or follow-up study. And this is particularly true of gene therapy, where they're being followed for a very long time because, once you give the gene therapy, it's done. Or if you have like an antisense oligonucleotide trial or something that's that you want to really know what the patients do over a long time after they start treatment. And sometimes and then the phase 3 patients may join the same long-term study. So there are a couple routes here to drug approval, and this is just a model that may often apply to diseases that are rare or to an agent like a gene therapy or a protein replacement therapy or an antisense oligonucleotide that's more than just sort of taking a pill. And so now I'm just showing here, the NNZ came in early, but NNZ-2591, which is the neuron compound that works on synaptic connectivity, is kind of between the early phase 2 trial and phase 3, but there's not a long-term extension yet, although there may be after phase 3. And the Jaguar drug is just going into phase 1/2, and it's a gene therapy. So this is where we are with current drugs in Phelan-McDermid syndrome. So now I'm going to talk a little bit about the challenges of clinical trials in an ultra-rare disease where we have a neurodevelopmental condition and where we have variability in the condition. And so things we have to worry about in the trial is recruitment. Will families be interested in being in the trial, and can we recruit enough patients without being coercive? Are families worried about side effects? Will everybody understand the difference between a trial and clinical care and the duties that people have as a trial participant? We'll talk a little bit more about that. Will families stay in the trial and be able to do everything that the trial demands and kind of keep doing it to the end? Because there are some things that are annoying, but we have to do them. What are the best assessments? What testing can we do that will not be too hard on the patient, but will still get meaningful data in terms of how the patient is doing? And can we set things up so that we get really accurate reporting and avoid alterations of reporting or placebo effects, thus masking the trial results? And how do we avoid bias and maintain the blind? And this is something I'm going to expand on a little bit more. Sometimes when people are talking about how their child is doing on Facebook or other social media, that can be really problematic for the trial. So just some solutions and strategies for these things. The PI should be available and supportive and explain things to families. We often have a coordinator who contacts families and tries to provide information. But what we try to do ultimately is if families still have more questions, really spend as long as needed to help people understand what the big picture is and what we're doing in the trial. And there should always be an easy route at the site if you're in a trial to be able to reach someone, usually the coordinator, but even directly the PI, depending on what the study is like. And then the families have to understand that it's not clinical treatment. It really is an experiment. We don't know how it's going to come out. It might be that the drug will work, and it might be that it won't work. And the expectations of what we are going to do are a little bit different from just coming to clinic. And we're studying the effects in a very controlled fashion, so we need to follow a protocol, even if it seems like we're doing things that are unnecessary. So the rules aren't really like clinical care, where we only do the things that we can really see are important at the time. And it's critical to follow all the rules and procedures, or the study may fail and show that you may not be able to show something is effective even when it is. So in order to keep people in the study, we try to make unpleasant things as easy as possible, using motivators and rewards for patients to get through procedures. Sometimes we use food to help with testing. We try to have things, we have families bring in the favorite items to help them. We try to provide schedules that allow families to know what their study days will look like. And families should come prepared for some waiting. No matter how well we plan a series of procedures in a study, there's going to be waiting and delays. It's a medical center, and that's what happens in medical centers. Things get behind, there are emergencies, and so there can be delays. And so it's good to have, a store of iPads, toys, DVDs, things that will be helpful for the patient while they're at the site. And then we try to minimize discomfort every way possible and anticipate things that will bother the patient, but we can't always. Some of the study procedures hurt a little, and so we can't always make that go away completely. When we're trying to do an assessment, we want to talk to you about what is the best time of day to do a performance-based testing. If we have to test the child, we want the child to be at their best. We want to have experienced examiners who know how to approach the patient, and but we have to be very consistent in how we do things so that everyone is interviewing and assessing patients exactly the same way across the sites so that we get consistent data. But we are often allowed to incorporate breaks, reinforcers, rewards when we're doing performance-based tests with the patient. It's when you're filling out a form about an assessment, it's important not to alter your report of symptom severity to qualify for the trial. There's usually criteria for how severe the patient has to be, or what kinds of symptoms they have to have, but it's very important for you to report honestly what the individual in your family has, because otherwise, if we get the wrong patients in the trial, then we may not be able to fulfill the design and show what we want to show. It's important to report all symptoms and changes observed accurately and not try to read into these or embellish or minimize. It helps if families actually don't know too much about the entry criteria, because we want you just to be honest about what is going on with your individual who's joining the trial. And if you think you've figured out the scoring system to get into the trial, I'll talk about this again later, do not tell other families. This is not helping anyone. We want to maintain the blinding. We don't want you to say things that may be unblinding or introduce bias on social media or telling other families about side effects or positives that you may have seen. And even if families suspect a treatment side effect assignment because of a side effect, you want to keep that between yourself and the PI in terms of telling your investigator at your site what you're seeing, but not telling other people. So we know that being in a trial is a lot of stress, especially when your child requires more care than a typical child. And I think coming into a trial, it's really important to educate yourself on what's involved and think about if you can do it. And if, depending on how the drug is delivered, are you okay with having a drug delivered directly into your spinal fluid or in the ventricles of your brain? Are you okay with anesthesia? Are you okay with gene therapy? The trial is going to go on for a long time sometimes, and can you really participate for the duration of the trial? You have to fill out diaries and assessment forms accurately and honestly, and you kind of have to do these when you're expected to do it, and you can't put it off for a month. So you have to kind of go into it thinking, yeah, this is something I can do, so that we have the best chance of finding out if the drug works. So if it does work, we can get it approved. And if we have incomplete data, then it will delay the trial, or we may not finish the trial, or we may not have enough data, or we may not have the result that we want. And so getting to completion is the goal, and we want to minimize. I mean, it's fine. Not everybody has to be in a trial at the beginning. You can wait for the drug to be approved. You can be in a trial, kind of after an early, really intensive trial that's maybe isn't quite as intensive, like the phase 3 is sometimes not as intensive as the phase 2. But we want everybody to educate themselves on what's involved so that you'll be all in and do everything. When we need you to do it. And in reality, in some of these early trials, there's a select group of patients that's going to participate because they're fairly small, and others are depending on you for their future treatment. So we want to make sure that we're all in partnership and we're all really working to move forward. One of the things you should not do, and I've talked about, I just mentioned this, is post stuff about your child's side effects or responses, or be in a Facebook group with other trial participants, or compare effects in your child with others in trials. I've actually had families come in and tell me, well, so-and-so's at the San Diego site, and they're having this side effect, and they talked about it in our Facebook group. And I'm like, what? Well, we want to know what you think about this side effect, because we're not sure their doctor in San Diego is right. Okay, that's not allowed. We can't do that. And I have to tell them, I can't tell you. They have to talk to their doctor. So we can't do this kind of sharing. It can cause trial to fail, and then no one gets the drug. You can post stuff like how much you love your trial site, where to find parking, how to get your safety bed set up in the hospital room, like what coordinator is your favorite, what the best route from here to there in the hospital is. But do not post, the video of your kids saying a new word or pointing out letters or anything that would suggest what they're actually doing in the trial. We had an experience in Fragile X that where social media probably prevented us from an actual drug approval, because people posted on Facebook how to rate the scale that we were using to qualify patients and what you had to rate, what score you had to get in the trial. So people inflated their scores, and then they got in the trial. And this was unknown to the investigators or the company that this was going on. And so what we had here, you can see in the green, the primary outcome was social avoidance. And you can see there's drug and there's placebo, and we almost got to statistical significance, but we had a huge placebo effect. And we did see a significant effect in some of our other secondary measures without quite as much placebo effect. The reason we had all that placebo effect was that people were fudging their entry criteria, and then as the trial went on, they of course got better and regressed to the mean, and so that looked like a huge placebo effect. People with Fragile X are still pining for this drug. It does actually work for about 45% of patients with a significant improvement in behavior, and we don't have it because of that. So families were gaming the system and caused this big placebo effect. Don't be the Fragile X field. Don't let this happen in PMS. This is my lesson to all other disease groups. We've learned about this in Fragile X, and we don't let it happen anymore, but we don't want to have that kind of a problem. So I just have these two things, these two little reminders. Do not post these. The top 10 things you should never post on social media are anything about how your kid is doing in a trial. Okay, I'm going to quit harping on that, but I really just want to, our participation is always really a partnership, and we have partnerships with our Fragile X patients and our Angelman patients and our PMS patients and our other disease patients. And really, we all work as a group, and we really need to work together to get these trials done. So now I'm going to talk a little bit about what we have to think about in designing a trial. So should we have a placebo, and how long should the placebo be? What should the dosing be? Is the dosing the same in normal people as it would be in people with a disease? Do we have an animal model to help us with that? Safety assessments. Our participants often are not verbal enough, or even if they are verbal, they can't really report accurately their adverse events. How do we figure out if a patient is having a side effect? The age of subjects, younger patients might respond better, but usually the traditional drug development process is from adults down to younger patients, and how do we navigate that? If it's an oral drug, can we get a liquid form or a sprinkles or something that's not a pill, because our patients may not be able to swallow pills? Do we allow other medications or not? And what can we use as our outcome measures that will measure the effects in a developmental disorder where typical measures don't work because the patients may be at the floor of the measures that were designed for their age level? And how do we navigate the fact that people with rare disease are often coming from a long distance? So we have a lot of things we do. Well, when do we need a placebo control? Well, in early safety studies, again, we may not use a placebo, but we're pretty much always going to need a placebo for a neurodevelopmental disorder in late phase 2 studies or phase 3 studies. And the reason for this is that there's a lot of variability in the symptoms, and as you all know, patients kind of go up and down in terms of in terms of being better some months and worse other months. There's a strong placebo effect for if we think something's going to work. Everything looks rosy and we think it is working. There can be inflation of ratings at baseline. There can be rater bias when we're trying to rate the patient. We want the drug to work too, but we can rate the patient as having an improvement if we know they're on a drug. There can be confounders like a medical thing or other medications that change or cause a problem during the study. And sometimes there can even be learning effects. We need the comparator to prove that the drug is better because the people in the placebo are doing all the same things as the people on the drug. And then if the people on the drug do better, that's showing us it was due to the drug, not all these other things that were going on in the background. Sometimes in ultra-rare variable diseases, especially neurodegenerative diseases, it may be impossible to find a good matched placebo group, and then it may be ethical and appropriate to use natural history or case control studies. PMS is not really in this category. Possible trial designs we have, everybody wants to get drug, right? So when it's an open label trial, like the first Neuron trial, that's great because everybody in the trial gets drug and in the phase 2 study, but that can't usually be a trial that we will use for FDA approval. Exceptions might be things like gene therapy where it's a very intensive trial and you're looking for dramatic results, and then if you have a really dramatic result, that might be enough to overcome the placebo. So the placebo-controlled trial may have an extension where everyone gets drug. It could be a crossover where in the first period you get drug or placebo, and then everybody crosses over and the people that got drug get placebo and the people that got placebo then get drug. So everybody gets to experience what the drug effect is like. Recruitment is usually easier for crossover and extension designs. If people know they're going to get drug, it's a little bit easier to, they're more likely to sign up for the study. We just know this from many experiences. An extension is usually justified in the later phase trial. You always need to have long-term toxicity, so you need to have people on the drug for at least a year. And this can go on, the extension can go on for quite a long time. And particularly if you have a disease where you're trying to measure something like cognitive change, you might need to have an extension of drug for years, but then you need all that natural history we've been collecting because you can't keep people on a placebo for years. Dosing is usually guided by preclinical studies. Sometimes we have a situation where we dose the first patients at one dose and then the other patients at the next dose and then more patients at a higher dose, and then we find what's the best dose. Sometimes we have a situation where each patient starts at a lower dose and then after a certain amount of safety, they go up and then they go up again after a certain longer period of safety. And this just shows all these different kinds of dosing designs that we can have. Sometimes you have a whole group of people that get different doses so that you can compare them. But one of the goals of especially early studies is to figure out what the best dose would be. Safety is always a little bit challenging. Everyone knows that even in standard clinical care, sometimes your child is irritable and you don't know what's wrong and you're trying to figure out what's wrong. You're going through that kind of list of things that might be wrong because you have a nonverbal child and they can't tell you what's wrong. And this is challenging in trials as well. So we can't question the participant. So we have to rely on the families who know their child the best and can come to the best guess about what might be the problem if there's something that's kind of non-specific. So we try to tell the family all the different safety problems we may have seen in animal studies or phase 1 studies so that they know what they can be watching out for. We have some comprehensive screens where you basically screen like every part of the body and every possible symptom that could be happening, and you ask the families this at every visit. But these are very time intensive, and we know that families don't like these. we always have this question about what age should we be looking at. And this is fairly straightforward when we're, working on, a drug for a common disease like diabetes or something. It always works down from adults to kids. But in developmental disorders, there's some question about whether you can actually know whether the drug has had an effect if you try it in adults. I mean, maybe it would work in kids if you try it, even if adults didn't have a response, because it is a developmental disorder, and you might need to use the treatment at a time when development is still happening. We do know that metabolism of the drug can be different at different ages, so we have to do this thing called pharmacokinetics, which is those annoying studies where you have to come in and have an IV put in, and then we have to draw blood every 2 hours or something, because we have to know how fast does the body metabolize the drug, and that may be different in a child than in an adult. So we have a lot of We talk a lot about what is the age that we want to treat at, but in a developmental disorder, if we have a drug that we think works on the underlying disorder, we are going to want to get to kids as quickly as we can, because obviously everyone really believes that you have more opportunity to change the development of kids. Now, that might not be true. We might, have some agents that work just as well in adults as in kids, but we need to find that out. Assessment may be better at younger age levels because kids are still in school, and we sometimes have a better handle on their functioning than if they're living in a setting where no one is paying as much attention about what their performance is all the time. And kids are still trying to be taught things more so than sometimes adults are not having as much effort to be, trained as kids do when they're in school. We always have a question about whether patients should be allowed to stay on their baseline medications. I think we've pretty much got to the point now where, we have medications that exist, but, in a disease like PMS, they're not life-changing. They don't change the disease itself. So in general, we usually allow background medications. In some, psychiatry trials, for instance, they don't allow you to be on background medications. But in developmental trials, at this point, we usually let you stay on the medications. They just have to be stable. We can't enroll you in a trial when you just changed 5 medications in the last month, because we don't actually know where you're going to be 2 months from now with all those medication changes. So generally, when we tell you the medicines have to be stable for a certain amount of time, that's because we're trying to get beyond the time where your child is still changing because of the medication changes. So that's the main thing that we will usually do in trials, is that you just have to be on stable medications. And some trials will limit the number of medications you can be on, because sometimes if you're on 10 medications for behavior, it's too complicated to figure out what's going on. So we have to limit to 2 or 3 medications for behavior or seizures often. Outcome measures are probably our biggest hurdle in neurodevelopmental disorders. We have to test, if you look at the whole range of PMS, we have a large range of functioning that we have to test over. And the higher or lower functioning groups may be off scale if we kind of shoot for the middle of the middle range of functioning for the disease. And there are very few measures that actually cross the entire range of cognitive or language functioning that we see in the natural history study, for instance, in PMS, and very few measures that are validated for special populations. And it's really not clear how well these get at the core defects that are important in the syndrome. And then, will the patients even cooperate for the measures? That's always another question. So we kind of need to guess what should be our main outcome. We do something called the disease concept model, where we ask the families what's most important to you. And I think in PMS, a very important issue is communication. And that in general, that's for more severe developmental disorders, that's generally a big issue for every one of these disorders. What we'd like to do, if we have a genetic therapy, for instance, and I'm giving a genetic therapy to somebody with a developmental disorder, I might see improvement in gross motor skills, in fine motor skills, in communication, in cognition. sleep, in seizures. It could be all kinds of things. So what ideally I'd like to do is measure the improvement across all those things, because different patients may improve in different areas, and I'd like to be able to add up all the improvements. Well, this unfortunately is not accepted by the FDA right now. They want me to pick the one symptom that's going to get better, which to some, you can see the faces on here. To some extent, this makes absolutely no sense, but we have to deal with it right now, and we have to try to work to hopefully evolve it and change it in the future. Sometimes we need special measures like disease-specific clinician impression scales that do kind of what we do in clinic, where we assess the patient in all different domains and decide whether they're doing better or not. These are not accepted as a primary outcome measure by the FDA. Or we can create specific disease rating scales, but these can take years to develop. And we're in the process of doing one for one other disease, and we're like in year 10 of getting this fit for purpose at FDA. So this can be a really long process, and sometimes it can prevent people from actually getting access to treatments because we don't have a measure that's appropriate for their disease. So this has been a huge challenge. We've worked hard on a PMS-specific CGI that we're hoping to be able to use in future trials, and through the DSC, getting our natural history study that Alex talked about. We've been working on getting understanding how a whole bunch of measures behave in PMS so that we can choose the best ones to show improvement in trials. Travel is always an issue for every trial. I think the good thing is that it's usually paid by the sponsor for industry-sponsored trials. The more clinical sites you can have across the country, the better it is. And we've actually learned how to do a lot of things remotely. We have a lot of measures that we can administer by video conferencing, and this increased a lot during the COVID pandemic and are being incorporated into many trials now. So again, we have all kinds of drugs that we give now in neurology. We have pills or liquid, and there's the swallowing issue. Can we, take a capsule and dump something out so that we can get it mixed up in applesauce or whatever, so that we don't have to worry about swallowing it? This all depends on whether the pharmacokinetics was done this way, and whether we know how, if we deliver the drug to the patient that way, do we know? I don't know, she's giving me a signal. I think I'm supposed to be done, maybe. Do we know what the blood levels are for that? And some things have to be administered through a spinal tap, and you can see a picture of us delivering a drug by spinal tap to a different patient population. And then some things go directly into the head, and here's just us accessing a port for Brineura, where we do the enzyme treatment directly into the ventricle in the brain. So there are a lot of ways of delivering drugs now. So I'm just going to go real quickly. I don't want to steal Neuron's thunder or anything, but I'm just going to talk real quickly about what's coming up right now for PMS. So trofinetide is the drug that Neuron originally started working on. It's an analog of growth hormone, but doesn't work exactly through the growth hormone receptor. It works through a lot of different pathways in neurons. And now they have NNZ-2591, which is more stable, orally bioavailable, and can cross the blood-brain barrier better than trofinetide. So this drug works on a lot of different pathways in the brain, and it theoretically might circumvent the SHANK3 deficiency by mimicking natural actions of cyclic lysine proline, which is a chemical in the brain. And then there's a whole list of things. I'm not going to read them all, but it's rescued a bunch of different abnormal pathway signaling and structure of the neurons and abnormal protein synthesis and other kinds of things that can be measured in SHANK3 deficiency or in animal models. And in the PMS mouse, there were deficits in memory and object recognition and rotor-rod performance, which is a motor test, and other kinds of behaviors that improved with this drug. So in the phase 2 open label study, which I don't know who, somebody's from Neuron is Liza is presenting, showed good safety and signal for benefit in PMS. And so this will be moving forward, and we'll let Neuron tell you all about that. So there are newer kinds of things that are going now in terms of the strategy to target the actual genetics of PMS. The neuron drug would be considered a downstream modulator that works on some of, once you don't have enough SHANK3, there's a lot of bad things that go on in neurons, and the neuron drug is working on those things. But you could actually say, let's just put SHANK3 back and try to fix the genetics, and in reality, it might work best to do both of those things together. So one way that you could do that was with an antisense oligonucleotide, where you work on trying to increase SHANK3 protein production. This is being investigated, but there are no trials yet. This is the kind of thing where you have to give this drug by a spinal tap every several months to keep it working. Or you could do gene therapy, which is generally a one-time thing, and we're using, as was mentioned earlier, we're using AAV9 vector for delivery, and Jaguar has JOG201, which will be given directly into the brain ventricles that's now in development. And the idea here is that you have a virus, and I have the picture here. You have the virus, which you have your gene inside. All the bad parts of the virus have been taken out, and now you have your gene in the middle of it, and then you're going to put it into the brain, and if you use AAV9, that'll go into the neural cells, and then it releases what's inside, which is your gene, and then the gene can start to make the SHANK3 protein, for instance. So this is very cool, but there are some issues with gene therapy that we are having to navigate. First of all, we have to figure out how many neurons we can get the gene into. Traditionally, it's been very difficult to get a high percentage of neurons to express the gene. We're looking to try to get up to like 20 or 30% would be good. We don't know if too much SHANK3, if we got too much of the gene therapy into a cell, would too much be a problem? It doesn't seem like there's a big indicator of that. Can you correct the genetic defect after birth and get normalization, and how much at what age? This is a huge question. This is a question for every developmental disorder. We do not know if the genetic correction would be the same at 2 months, 2 years, 20 years. Sorry. We just don't know. And this is a question we're just going to have to answer. For some conditions, for some conditions, it may be possible that you can get the same correction in adults as younger patients. For others, maybe not. So we're only going to know this with time and with doing these experiments. And the other problem is that you get an immune reaction to the viral vector, and so you can only give this once. And if you give a low dose, sometimes you give a low dose in the early trial, and then you go up on the dose, and the low dose participants might not have gotten quite enough, and they might not have as much effect, and this is kind of an issue. It is thought that you could probably redose people who get the drug into their spinal fluid, because the spinal fluid is kind of a protected category. Oh, thanks. Because the spinal fluid is kind of a protected category, area, compartment, and you don't get as much immune response in the spinal fluid as if you give the drug in the blood. But we don't know that. So we don't know if we'll be able to dose again, or if the gene therapy will actually wear off in 5 or 10 years. So how do we give a gene therapy? Well, you cannot give it by mouth. You can't get it to go from the stomach up into it's just not ever going to work. And not enough gets into the brain from an IV delivery because of the blood-brain barrier. So we have to give it into the spinal fluid, and we can do that through a spinal tap, or by putting it directly into the ventricles, which are the fluid-filled spaces in the middle of the brain. Or we can put it in the back of the neck, up high in the spinal cord, where there's a space called the cisterna magna that we can inject a gene therapy into. We don't know all the answers about what is best. My belief is probably closer to the brain is probably better, because the brain is right there, and then the drug can get into it. This is just pictures of delivery. When we do a spinal tap, we put it between the bones in the back, and we go into the spinal fluid and just do an injection. That's very safe and actually very easy. The other two approaches require you to be under anesthesia, completely under anesthesia and immobile, and require neurosurgery. So when we put it in the ventricle, it goes into that blue space in the middle of that picture of the brain. When we put it into the back, of the neck. It goes under the cerebellum, and you can see where you can see the pointer where we would put the gene therapy there. So there are pros and cons to each of these. The ICM and ICV delivery are they're more invasive and they're more intensive and they have more risk. The spinal tap is much easier to do and has less risk, but can you get enough gene therapy to go all the way up the back into the brain is the issue there. And if you're only doing it once, in some ways you should, go to try to, really solve the problem when you do the treatment. And this is just a slide to show there's a lot of, this slide is falling apart. I don't know what happened. But anyway, there's a lot of different diseases that are gearing up with natural history studies and treatments of the underlying genetic disorder, and I don't know what went on with that, but I'm just going to do all this. Okay, so there's a lot of these gene therapies and antisense oligonucleotides, which are like a genetic therapy that bind to RNA and kind of correct how much protein you're making, as well as drugs that work on synaptic connectivity or downstream effects that are coming forward in neurodevelopmental disorders. And we're really hoping we're moving, including PMS, toward being a field where we're actually treating the underlying disease rather than just treating symptoms. And that's all I have to say. And I just want to acknowledge all the groups working on this, Jaguar and Neuron and the PMSF and CureShank and the Developmental Synaptopathies Consortium, which has really laid the base for us to understand how to run the clinical trials. And I'll take questions if I'm not too much over.
Thanks, Liz. Hi, everyone. I'm over here. So we're going to put up a poll for questions. It's the same format if you were in here earlier. We only have a few minutes till the end of this section technically, but we do have a break in between, so feel free to keep asking questions if you scan the QR code, and also upvote other people's questions that you want to see answered. I'll try to ask the top ones. Please keep these to general clinical trial design questions. She could probably answer questions about Jaguar or Neuron, but we also want them to be able to do that themselves in this next session. So if you have questions about design, anything like that, please ask them now. And I'll just give it a minute for everything to populate on the screen, and you can like other people's questions. So one of them I'm already seeing here, and I'm just checking on my phone, is, do you need to be in a natural history study to be considered for trials?
So technically, no. I mean, we would recruit outside the natural history study. To be in, for instance, Neuron they're going to talk about it, but they'll run a phase 3 study, and that will be a placebo-controlled study. So for that, the placebo will be the main control. And of course, we always like to have people from the DSC who contributed and we have background data on to participate, but it won't be restricted to that. If someone is interested, they can participate. For a gene therapy trial, though, where you may be trying to show a dramatic effect and you are trying to maybe avoid trying to do placebo for gene therapy, it's always helpful to know what the patient did, for the last 5 years, so then you can compare what do they do after they got the gene therapy, for instance. So I think it's preferential to be in the natural history study in a case like that, especially when you're only recruiting a few patients at a time, but I don't think it will be absolute for any trial.
Thank you. There are 2 very highly upvoted questions. One of them is just generally, what are the risks of something like an ICV delivery?
Okay, so the this is a source of argument among even industry. You can ask 8 different, industry partners about why they're doing ICM or ICV, and they will all think that there is one way to do it, and that's absolutely the better way. And so there's no agreement in the field on which is better. However, so ICV, they're going to actually put a catheter through the brain. On the other hand, this is something that neurosurgeons do all the time because it's how they treat hydrocephalus. It's how they put in, shunts and ports and things like that. So it's a very commonly done procedure that they consider their bread and butter. So it's considered an easy procedure. There's concern that as they pull the catheter back out when they go through the brain, they could track the virus with it. There are various thinking about that's complicated. It's a pretty simple surgery, so you go under anesthesia. And the risk, of course, anything can happen during neurosurgery, but the risk is that they'll hit a blood vessel, or there'll be some bleeding, or there'll be, a complication like that. But the complication rate is pretty low. ICM is a little more tricky, where you have to really be careful where the needle is because you're right by the brain stem. On the other hand, you do not have to go through the brain. You're really just doing kind of a glorified spinal tap way up high. And so if you get a person that's very expert at doing this, there may be less risk than going through the brain. So there's balance. Most companies will decide to go with one or the other. You definitely have to be under full anesthesia so the child does not move a muscle while you are doing either of these procedures.
Thank you. That was very thorough. We got some questions similar to this earlier as the top question, where there are different genetics underlying Phelan-McDermid syndrome. And as many people know, some people have deletions, some people have variants in SHANK3, and of the deletions, sometimes people have ring 22. So I think the overarching question is, will these therapies work for genetics underlying Phelan-McDermid that aren't just a variant?
Yeah. So we do know that there seems to be more higher functioning patients who have small deletions or mutations within the gene, but we also know that there are patients with a mutation in the gene who have as much problem as our patients with bigger deletions. And then we have some patients with, decent sized deletions who function pretty well. So the genetic correlate is not absolute, and even with ring 22. So we think the main gene in the big deletions and the ring 22 is, SHANK3. So in theory, all these treatments should work across all the different forms of SHANK3 deficiency. Now, you always do have to worry about all those other genes outside of SHANK3 when you have a big deletion or when you have ring 22. And so it could be that there are other contributing genes that have a little bit of impact on the patient's condition. On the other hand, if you fix the SHANK3 part of it, then probably you're going to see benefit. It's possible that we would see more benefit in a person that only has a SHANK defect, but we don't know that. I mean, SHANK3 may drive most of the effect for some of these larger deletions. So I think we're looking toward treating the whole spectrum of SHANK deficiencies, and we'll know as we, sort of do the trials, how well it works for one type versus another. Some trials will start with one kind of deletion and then move to, larger deletions, for instance. Others, may enroll across the spectrum.
I think I'll go with two other top questions before we transition to our next session. Another one that we get a lot that I've seen in here is, what about other countries, people in other countries? Can you speak in general to how it works to the clinical trial sites and whether or not international folks can participate?
Well, I think that's really up to the company that's running the trial. If they are an international company and if they have the resources to do all the regulatory submissions in other countries, then the trial may run in multiple countries. If it's a smaller company and they're really focused on getting FDA approval, they may only run in the US, or in some cases they may only run in Europe for the EMA. So I think that really depends on what is happening with the individual company. And then sometimes after an early phase trial, the trial may expand to multiple countries because it's seen to be safe and it looks very promising, and the company is trying to spread out to get approvals across the world. So this is highly variable, and really depends on what's happening in the specific development of the drug itself.
And the last one, I'll answer a little bit and then see if Dr. Berry-Kravis has any additions, but how do I put my child forward for trials? So essentially, the second that the clinical trial is open for enrollment, we will know about it. The sponsor will educate you about it. We will put it out on all of our channels. We will email you. We'll put it in our newsletter. So you will know, and there will be contact information on there to be considered for screening. There are pretty extensive screenings usually for these things. And do you have anything to add to that, Dr. Berry-Kravis?
Yeah, I mean, I think for the DSC participants, what we try to do with all of our participants is collect information on whether you are interested in trials, and if you are interested in trials, are you interested in one of these more intensive trials like a gene therapy, or are you more interested in doing a trial of like an oral medicine? And so we try to get a sense of that. But if you want to remind your DSC site what you're interested in, then that's fine too. We actually keep a recruitment list of what everybody who's been to our site has told us they were interested in doing, so that we can pull from that when we're starting to recruit for a trial. There's also a website called clinicaltrials.gov, which lists all trials. It's mandatory for every company to list all of their trials on clinicaltrials.gov, or even an academic trial. So if you go on that, and they have to list as each site opens, they have to list that the site is open, so you can find out what sites are open from clinicaltrials.gov. And even if you're not in DSC, the sites that are going to be on the trial are listed on clinicaltrials.gov and probably at the PMSF also. So you can just call the coordinator that's listed for that site and make sure they know you're interested and try to get on the recruitment list.
Thank you. That's perfect. Thank you so much, Dr. Berry-Kravis. I know it's amazing. We have just a few minutes till the next session, so please sit tight or don't go too far, and Nurin and Jaguar will be presenting at 2:45.